All right, without further ado, we're going to go ahead and get started on our next webinar. So this webinar today is part of our fall series. We're joined by Dr. Cuello-Garcia, who will be discussing guidance on optimizing the integration of randomized and non-randomized evidence with a discussion and question and answer to follow. So if you do have any questions as he's presenting, feel free to put them in the chat. Please make sure you follow us for updates so you can be aware of all the future webinars as well as other events that we do throughout the year. You can find us on Facebook at US Grade, Twitter or X at US GradeNet, and Instagram at Evidence Found. And of course, you can also find us on YouTube, where all recordings of previous webinars can be accessed at any time, and that's at US GradeNet on YouTube. Feel free to subscribe and make sure you stay aware of all of the webinar recordings that we have to offer. We do want to make sure you're aware that very recently we have announced our next grade guideline development workshop. This will be our 22nd workshop. This will be held in Arlington, Virginia, just outside Washington, D.C., May 7th to 9th, 2025, and with a special focus on grade for diagnosis. So we only do grade for diagnosis once every few years. So this is a very great opportunity to join us in DC and get hands-on experience learning about grade and specifically applying it to diagnosis guidelines. You can please take a look at our applications for our scholarships. So the Evidence Foundation does provide scholarships for a few applicants for each of our workshops to attend our workshop to register free of charge. So there's no registration fee for attending. You can find information and details about how to apply at evidencefoundation.org/scholarships.html. And those applications for the next round to meet us in DC will be due December 31st, so just about in a couple months. So take a look at that and feel free to get in touch with us if you have any questions. And with that, I'm going to turn it over to my colleague, Philip Dom, who will be introducing our speaker for today.
Yeah, thank you, Madeline. Welcome, everybody, on behalf of the US Grade Network and the Evidence Foundation. It is my great pleasure today to introduce our distinguished speaker, Carlos Cuello-Garcia, who is faculty at McMaster University. To give you a little bit of background on him, he is a native of the country of Mexico. He obtained his MD degree at the Autonomous University of Nuevo León in Monterrey, Mexico. He then specialized in pediatrics and then joined McMaster University in 2013 to pursue his PhD. After completing that, he joined the faculty. He is now, among other things, a faculty at McMaster in the Department of Health Research Methods, Evidence, and Impact, where he devotes a lot of time into method development. He has since this time, made some major contribution as it relates to systematic reviews. For example, he was part of the Lancet systematic review on COVID. He has worked with many guideline developers, such as the WHO, the American Society of Rheumatology, ASH. But what he's really best known for, I would like to say his name is nearly synonymous with this work, has been the grade-related work on the integration of RCTs and non-RCTs, which we will talk about. So I would say there's no one better than Carlos to talk about this topic, and we are really very, very happy to have him today. And I very much look forward to this presentation, Carlos. Please take us away.
Thank you, Philip. Thank you, kind words. And hello, everyone. Happy to join and to see all the familiar faces for the US Grade Network. You have a big day tomorrow, I know, so I hope you participate. It affects us also, yes. Anyway, let's start. I'm going to share my screen. Let me know if you cannot see it. Yeah. Great.
That's great.
So, yeah, perfect. Okay, so this is the topic of randomized and non-randomized studies integration in evidence synthesis of health interventions. And I want to emphasize the word interventions as opposed to exposures, which is another topic that Rebecca manages really well. And yeah, so it is mostly about treatments. Before that, I don't have any conflicts, financial conflicts. I also work for the Canada Drug Agency. I want to thank for the support. And as already mentioned, all my other conflicts are maybe academic only, but not financial. So what we can review today in this next 45 minutes is the most recent grade guidance that has been approved lately and is soon to be published for the integration of, for the inclusion of non-randomized studies and evidence synthesis of health interventions that uses also randomized trials. And these can be used, or I use usually for decision-making in HTAs or guidelines. So we want to explore all of these different scenarios that we can obtain, we can observe when we have the opportunity to include non-randomized studies, also called observational studies, with randomized studies. So this is the differences in the grade assessments in both bodies of evidence and how can we interpret, present, assess the whole impact of both bodies of evidence on the recommendations. So as an initial introduction or as a background, many of you may know this patient. This was a famous patient here in Canada. In 1922, he was the first patient to receive insulin. And the point of presenting this case is because it's very applicable to many of the questions that even we have today, although we don't find cases like this anymore. There is always the great certainty in our minds when we see those kind of cases that we say, okay, how is possible? What is the causal effect of one intervention to an outcome? So grade what does, and we know that grade what we do in grade is rate the certainty of an effect or true causal effect, that if it lies on one side of a specified threshold or within a chosen range of a magnitude of effect, as we lately have seen in our recent guidance for imprecision, and now in the new book of grade is updated with specifying that this true causal effect lies on one side of a threshold or within a magnitude of effect. So the question here is, what is our certainty that insulin reduces death or other undesirable outcomes in these patients? So imagine you travel back in time to 1922 with all the momentum and your knowledge that you have right now, and you are asked to assess what is the certainty of the evidence, and if you will, what would you do to prove that this intervention called insulin reduces death and other undesirable outcomes? And in your mind, you say, well, in my mind, I should have the same question. Does insulin causes less death or no versus no use in insulin? Obviously, that is only in your mind. You cannot run with your knowledge a randomized trial in that case. But you see the effects of this insulin, that before the invention or discovering of insulin, all patients died, 100% of patients died. Now with the intervention, nobody dies. So the thing is that you cannot run a randomized trial. And the thing is that maybe you cannot even run an observational study. It will not be ethical to conduct a comparator arm of patients just not receiving insulin, because you see the effect that is so amazing. So maybe you can start thinking about what is the next best design that you can go for. So you can go even for maybe an historical comparator. Okay, before this discovery was here, all patients died. Now you have insulin, none of these patients died. And that's the best evidence that you can form maybe in that case. So yes, that's the evidence that you will use at some point for your guideline or for your HTA. And that's the point that sometimes obviously in nowadays, we don't have cases, or mostly not cases like this, what we call parachute examples, where the effect is super large and you don't have to run randomized trials, or you cannot run randomized trials in this case. But the question is the same. And in your mind, you can have initially your target trial or your estimate. The thing is that I want to have in my mind what is the best design possible, and then from there going to what we can obtain in terms of data. But the question is the causality of the effects. If coffee produces heart attacks, and if we have any other things in consideration, if we have confounders like tobacco, that is actually the thing that causes the heart attacks and not that. So we have to think in a way of what is the causal estimate, what are the confounders, what are the mediators, what are the colliders, etc., to consider the best design possible for my observational evidence. In this case, insulin is very, very strongly associated to dead or alive. And even if we consider other confounders like socioeconomic status, this effect is strongly attached from cause to effect, that I cannot ignore this large effect. Now, saying that, you can think with that what the history has said throughout to specific designs in many questions that we have in history. For example, the classic example in the reason of why many of the systematic reviews, why we prefer randomized trials over non-randomized trials. So in this question, for instance, we have if patients experiencing menopause should use hormone replacement therapy to reduce cardiovascular events. If you remember, there was data before that it says that using hormone replacement therapy decrease the risks of major coronary disease or cardiovascular events of any other types, but mostly about in this case. So it was a very famous study in the 90s. Many people received hormone replacement therapy, and this was based on observational data. But we know now that this data was wrong. But the point is why it was wrong and why it was so different for the observational study of 0.40 here, the original one. Then a randomized trial was run. And that randomized trial confirmed that there was no association between the use of hormone replacement therapy and cardiovascular disease. So there was this difference that was, hey, we know that observational studies overestimate or underestimate, and we should not consider. However, with the evolving of the methodologies and evolving of discovering what went wrong initially with the observational studies, we have now more knowledge about what can go wrong in observational studies, and we can aim to avoid that. For instance, individuals researchers from Harvard had started reanalyzing this evidence from the observational studies, or the initial observational studies with the same data, and they were run fixing those problems that they had. And nowadays, obviously in hindsight, it's obvious that they had issues that if you run it again now with new target trial emulation techniques or new statistical techniques, you will obtain similar results to what now we see from the randomized trials. So the point is that you can have not only the use of good adjustment of confounding between the intervention and the comparisons, and you can also, and you should always consider other things like the use of the time zero. For instance, in that case, the error or the main mistake was that people did not consider in this missing period where the start of follow-up and the start of intervention were different between those patients assigned to hormone replacement therapy and no hormone replacement therapy. So you have an immortal period or immortal time bias that was the culprit of that difference, that huge difference. So all of these techniques, the point of these examples is that things evolve, even these techniques and these new methodologies evolve. If we have more information now than before, and observational studies have been improving overall in the sense of attaining the causality relationship between an intervention and an outcome. So that's why the target trial is important to always consider in situations where you cannot run a randomized trial. If you remember the initial parts of the COVID pandemic, when we have a lot of questions but no randomized trials at hand, we asked, what is the role of tocilizumab? What is the role of masks or the remdesivir? And we only had indirect evidence or evidence from observational studies that were just beginning we were beginning to obtain, for instance, from registries. And they can happen in other issues or in other situations like rare diseases where you cannot conduct a randomized trial, or cancer drugs that it is not possible, or we cannot obtain randomized trials, and you can go for the next level of evidence of obtaining what will be the best next design and what will be the problems, and detecting those problems is better if we have in mind the randomized target trial beforehand. So overall, that was the reason that the new techniques and the new tools for assessing risk of bias try to consider an equality between randomized and non-randomized studies. So overall, if you see the new randomized risk of bias tools for randomized trials and non-randomized studies, they have these similarities posted together, that the issue of not having randomization, you can have these three new, or these three risk of bias domains in the observational studies, while you can have these in the randomized trials. Overall, these differences are usually mainly because of the randomization situation. But if you all go beyond that, the domains in risk of bias are pretty much similar between observational studies and randomized trials. So this equation also impacted how we grade the bodies of evidence. You remember the classic approach is to consider non-randomized studies as low certainty and high certainty those of randomized studies. This was mainly because of the risk of bias situation, that we inherently knew that the observational studies had these issues of possible residual confounding or other issues, and that experience from the history that the observational studies overestimate or underestimate, and we had less confidence that that effect was a true effect. However, with these new techniques or this new assessment of risk of bias, we can give the non-randomized studies the benefit of the doubt that, okay, maybe if you were conducted perfectly or better, or if you assess the issues due to randomization, you can start as a high level of certainty, but still you have to address the risk of bias, even be more careful with this risk of bias with using the Robin size tool. And you can still, and we will see in the next slide that it's highly recommended. It's still considered that the residual confounding is there. You have to address the time zero that I just mentioned, and other issues of risk of bias that are inherent for the observational studies. Obviously, there's still a lot of things to do for improving observational studies, and as the same as RCTs, they have problems, and we always address the risk of bias no matter what. The thing is that we can equate that, we can put it in the same level, and then go down with the domains that write down the certainty of the evidence, or rating up for the domains that you already know in gray, and ending up with a high, moderate, or low certainty, or very low certainty of the evidence. This also come up with a situation that we started thinking about how can we use non-randomized studies. And this is a famous paper from Holder that you maybe already know on what will be the uses of observational studies in synthesis of randomized trials. So when you can use it as complementary information. You can use it in sequence, or you can use it as a replacement. And this also gave light to the great guidance that has been already published, the great guidance 24, where we said from all of this information from the beginning, what can we do from the outset that say, okay, in these cases, we know that we will need observational studies. So we can go ahead. For example, if we are assessing baseline risk, we usually, in a guideline, we usually go straight to the observational studies. Or when we know from our scoping review or from our information from my clinical experts or other situations that the indirectness will be very high in RCT. So let's go with the observational. Or in serious emerging conditions like COVID, etc. So all of these situations in the blue box tells us that we should go ahead and look for observational studies for this PICO question. And then you can go, you go ahead with the process. It's very advisable. We suggest that you perform well scoping review the literature, where you can overview what will be the horizon there. What will be, you say, observing in terms of will RCTs be available or not? And this can be done in the protocol phase of your review, and you will have an idea of what will happen. So if you have a good idea that you will have RCTs, even though if you don't look specifically at them, you know that there will be RCTs, so you can go ahead with this flowchart. If you are very certain that you will not have any RCTs, well, it will save you time and just go full for the only systematic review of observational studies. If you go the way of this way down, you can perform the search strategy for both observation and RCTs. And the recommendation here is to evaluate your RCTs first, because you have the opportunity of the situation. It's possible that you can have good information from RCTs, and in that case, you don't need the observational studies. But for that, we recommend using GRADE. And in GRADE, if you are highly certain of your information, of your effects for this outcome, maybe in that case, you don't need observational studies. If you have, however, very low, or even moderate certainty, you can go ahead and go back to your database and look for the observational studies, and then use them together with the RCTs, or consider them, use them together. And that is the next step of our guidance. If you remember, this is where we ended in the last guidance, or saying, okay, maybe you can use both. But then the question was what to do next. Now I have both bodies of evidence. I have RCTs, I have no observational studies. What to do next? Because I have questions. So do they agree in the results? Sometimes maybe one says one thing and the other is the opposite direction. What is the certainty of the evidence on each? What are the domains affected? That is very important. And what is the effect of the certainty one over the other that they can interact? And what will be the impact on the recommendations? And finally, how to present them if we decide to present both, how to present them in the summary of findings tables or in the evidence profiles. So the options were, do we keep them separated? Sometimes you can keep them as two separated in your systematic review forest plots or even PICO questions. In one case, you can keep them together, using as a subgroups, classic effects in classic subgroup presentation with a final pool estimate, or do we combine them no matter what kind of design do they have, or even just keeping one. At the end, you can say, okay, maybe it's only worth to include only one. And the final presentation also had an impact on our new guidance. Well, do we present both separated like this, or both separated with a pool effect, or you can use footnotes if you decide to include only one, and include in the footnotes your assessment of the other body of evidence. So that was the guidance that was needed, but we encountered some issues on the way, because we realized that when we grade RCTs, if we take into account all the possible domains and all the possible situations for grading a body of evidence of RCTs, we have 139 possible situations or scenarios. And for observational studies, you have 140, there's one more. And if you combine all of these, if you say, okay, give me guidance for each of the situations, you will end up with 19,460 possible scenarios to discuss or to be guidance. So if you have high certainty in one body of evidence and high certainty in the other, that's an easier scenario, but you have to go through all of these because of the situations or the causes of the certainty of the evidence. So what we thought it was more a pragmatic way to face this situation, and pretty much it was that okay, let's assess first the certainty evidence of the RCTs, because those are initially or inherently the ones that are more likely to give you higher certainty of the evidence if they are well designed. But you also have to consider the certainty evidence on the non-randomized studies, and then assess the congruency of effects. If they are disparate, when they have disparaging results between one to one side and one to the other side, maybe it's not a good idea to consider them together and just discuss what will give you which one will give you the most, the highest certainty. For that, we will apply some grade principles, and at the end, we can move these to the grade tables and the recommendations. So the first thing that we will have to discuss is the congruency between RCTs and NRSI. So what is the similarities between these two? So the agreement between RCTs and NRS has been evaluated by several authors through time. It's been a nice topic to see. Several meta-epidemiological studies have addressed these differences between observational studies and RCTs, and pretty much what they do is comparing the results, the final results of each of the meta-analyses for the same pico question. Most of them agree, or all of them agree, that most of the estimates from observational studies and RCTs, and the majority of them, they are in agreement. So the discrepancies between observational and RCTs, as classically known by methodologists, is not that common as we used to think. And things have changed through time. But the point here is that the methods they use to measure this congruency, I mean, they are statistical methods mostly, or visual methods like this one, and those are the ones who are used to address this discrepancy. However, they might have some nuance to consider when we use grade. So, for example, we see that they use visual comparisons, for example, in this case, or they use statistically significant results versus not statistically significant results. So if you cross this line, you are not statistically significant, and versus this one, and they will consider this discrepancy. Or they use tests for interaction as a group. So if you follow a p-value of 0.05, you are different, and if you are above, you're not different. Or using relative effects of relative effects, for example, ratio of relative risks. And if you have a ratio of relative risk of 1, it's okay, you are not different. Or if it is beyond the 1, you are different. So the problem with these statistical sets is that they may have, some of them have a low power to detect these differences, but they also don't embrace the classical grade guidance of considering the magnitude of effect and embrace the uncertainty of this magnitude of effects that we have, and also the thresholds that we usually have in grade. So to consider the thresholds, to consider the magnitude of effects, the certainty, we decide to use those thresholds to address if one body of evidence will be different from the other. So we recommend to use your thresholds always as much as possible if you have them, and consider the similarities between both bodies of evidence. For instance, in this case, these studies, especially C number or example B, even though they are on different sides of the null effect, they are in the trivial or no effect range of the magnitude. So both are trivial, or they both had trivial effects by the standards of grade, and they will be considered in our flow chart, in our decision-making process, as congruent effects. The same here in this, in example C or example D, we have congruency in effects of both of these. Obviously, there is nuance, but the classical, or the definite incongruent effects were those, and these will be definitely incongruent effects, where you have very different confidence intervals and effect estimates in different size of the magnitude of effects ranges, or if you are using only threshold, it will be in those different thresholds. So it's important to consider that, because if you are not using these ranges of magnitude of effects, example G, you will have, if you're not using them and you are using only the minimal effect size or the minimal important difference here, these will be considered congruent effects because both are on the left side of the minimal important difference. However, if you are considering the ranges of magnitude of effect, this will be considered incongruent effects. So that's the nuance that we have to consider in your guidelines. So there are situations, obviously, that we cannot manage because there is imprecision. Low sample sizes will produce wide confidence intervals, so our uncertainty will be there no matter what we do. In that case, we will need to address if this is probably congruent or probably incongruent. For this, we recommend always using also the absolute effects of the interventions that you are addressing, because if you use relative risk, you know that it can give you a different effect when you're using the absolute effects. And there are many situations that you also have to consider when you're calculating the absolute effects of the absolute difference. There's a nice recent paper, a new paper, well, how to address absolute effects. But the point here, the important is that you should be aware of those. That if you use, for example, relative effects here, you will see that these both look very different. However, due to the small baseline risk of both of these situations and the small number of events compared to the total sample size, you can have differences. So if you use, for example, the ratio of odds ratios, they will be stated as very different. So this will be considered incongruent effects or different effects. However, if you use the absolute effects and you use a threshold for, let's say, 10 per thousand, you will see that that difference is not that much in the real world or in your guideline. So if you're using a guideline and you're using thresholds, or we recommend that you use better the absolute effects for calculating this effect, because these are the nuances that you can manage or discuss during your guideline development group. So this is in the new guidance that will come up. And we shared this in Miami, in other workshops recently in Prague. And this is just what I just mentioned before. So how are the confidence intervals? Are they completely separated by thresholds or not? And the nuance of when you have probably incongruent or probably congruent. Obviously, this is a judgment call. You should decide if these are probably congruent based on these estimates or probably incongruent. So this is that was the topic of congruency or incongruency. Obviously, if you have both body of evidence as congruent, that helps you a lot to consider your body of evidence together. But if they are incongruent, the thing is that we will recommend not using them together, or especially not pooling them together, because that will create problems in your body of evidence. And you should always explore what is the reason that one is in one side and one is in the other side. So then after that, you will apply what is the certainty of the evidence and together with your congruency, and then apply some grade principles to use in your grade tables or recommendations. So I'm going to give you a too long didn't read about all the guidance that we put there together in the sense. So the main messages for each of these domains in grade, this was obtained from all the meetings that we had in Krakow and before that in Washington and other places, about what to do in the sense that what will be the main rule of thumb, rules of grade. For example, if you have risk of bias, and when you address the domain of risk of bias, whether in RCTs or NRS, and the integration between they both, you should address that risk of bias. You should not mitigate risk of bias in one body of evidence due to no risk of bias in the other one. So risk of bias should not be improved in one because the other doesn't have it. However, you can still pool in some rare cases where you have a similar risk of bias, for instance, and the only issue in the other situations is imprecision, for example. So the big no's in this case will be not mitigate the risk of bias in one body of evidence due to the other. Also for inconsistency, you do not mitigate inconsistency in one body of evidence because the other doesn't have it. The only thing, and you don't pool in this case, if you have inconsistency, that is a red flag that we consider if it is present in either body of evidence, we should not pull the body of evidence, instead manage them apart and decide which one will give you the highest certainty of evidence. However, we decided in certain situations, for instance, if you have inconsistency in the randomized trials, and you don't know what, I mean, the reason of that inconsistency, you have only heterogeneity, but you don't know why it's there. And you observe in observational studies that there is these subgroups that were detected based on the observational studies. In that case, you can investigate further in the randomized trials and decide, okay, this inconsistency was due to this factor or this variable, and then we can address that part. That would be an example. That is a theoretical one. We don't know an example, a real one, but that's the only situation that we could come up with. So in terms of indirectness, one body of evidence can mitigate indirectness in another body of evidence, but we will not suggest to pull in that case. For example, if you have a guideline of, say, children addressing, let's say, pancreatitis, for the treatment of pancreatitis with oral interventions or food instead of NPTs or no diet at all. In that case, you don't have evidence or only have evidence from observational studies, but you find that there are RCTs in adult populations that can be used in this case. So in that case, that is the only thing that maybe the RCT can be used instead of the observational studies, or the RCTs can confirm your observations and the observational body of evidence and do not write down the indirectness in that body of evidence. That's one possibility. There are some guidance out there as examples, and we can share more if you need. In terms of imprecision, we do not mitigate imprecision in one body of evidence because the other doesn't have it, but we should consider that if imprecision is the only problem and both have, let's say, the same risk of bias, it is doable to consider a pooling in that case, and that will be only the similar case. So only imprecision and risk of bias together can manage to, at some point, consider. However, always consider and be very careful, and we mentioned this, we emphasize that part, that even in those cases is very, we suggest that we should always present the body of evidence or reasoning in a transparent way, and if possible, do a sensitivity analysis if applicable, or the way it will be applicable for every situation. In terms of publication bias, there is not much to do in that case. So we do not recommend mitigating for publication bias in one body of evidence due to not in the other, and not pooling, because usually the situation or the reasoning for the publication bias might be different between RCTs and observational. So this was the main messages or main conclusions from all our meetings with the GRADE non-randomized studies working group through all our meetings. And based on that, we ended up with a final infographic or figure to put all this together. The congruency of effects, the certainty of the evidence in one body, the certainty of the others, and what to do overall in general when you have one situation over the other. Obviously, there is nuance, and there may be exceptions that should always be established in your presentation and established in your footnotes, or established any way that you can be transparent and present it. And the options to presentation as well. So you can have both body of evidence together in a single summary findings table or evidence profile, or if you decide to pool, that will be the rare case, that you should put the two and the pooling effects. Or if you decide to use one single pool effect, that is a rare situation, you should always put your description in one in that evidence profile or summary findings table. So it's important to know that the situations that is possible to pool will be rare, at least as it is now, and you should always be very, very wary of situations where observational studies are still, we still have this situation where many are not considering this new methods or new techniques to address the risk of bias due to confounding, or the risk of bias for the time zero that will be created, the domain of selection bias, etc. So it's important to consider all that, and that is pretty much the guidance that will become up. So one quick example, this is cholinesterase inhibitor for patients with dementia, with the outcome of mortality. You can see will look similar in this case, and you can consider the effect estimates in both rows, one for RCTs and one for observational studies for the same type of question. Even when you're working on this, you can decide what is happening in this case. For instance, in this case, you have 12 RCTs. The risk of bias was considered serious, and the rest of the domains were okay. In this, give you a moderate certainty. In all-cause mortality, the observational studies also were considered serious because they were overall well conducted. You can see here that we use Robin's eye, and in this case, it was rated down one level only because the non-randomized studies use propensity scores or inverse probability premium weighting techniques to address for most as possible for residual confounding, even though you still can have residual confounding. And time zero was well determined, so we decided there's only one level down. But you can see here that there may be differences or nuances in this case. For instance, this case, in the original trial, you have 4.7% of mortality in the control group, which is a baseline risk that is very low or not mirroring the real life. For example, in the observational studies, you have a mortality baseline of 37%. And based on clinical expertise advice, this is usually more in real life. It is more close to real life. 37% is more closely than this one. So this you should consider. I didn't write down for indirectness, but you could even consider, say, that maybe these patients are not representative of my population or what happens in real life. And you should consider all of these nuanced situations that can happen, these differences in like in a regular guideline. And all of this is, the point of this is that you can consider many situations that can have an impact on the decision of using one or both. So you use these baseline risks as it were, you see that there's a big difference. And if you use this threshold, it will be a different decision one versus the other. So you have to think about that. You have to provide more evidence. For instance, this baseline risk at 1 year is in agreement with the observational data, and this is from observational data, which is what we do. And if you use that risk of 20%, now it aligns both of these new effect estimates are more in alignment with what we consider. So the point is use absolute effects, consider the baseline risk that we use in that, and if you use your thresholds, also consider, follow the other great guidance that we have at hand that we can use for the threshold, the magnitudes of effects that we do. And final example of the target trial of the tocilizumab one, that's another good example of observational studies using, some of them using propensity scores or target trial emulation, which is this one, the Gupta 2021. Most of these were first published before their randomized trials. And people needed evidence, in advance, and they needed, even if it came from observational studies. In that case, these new techniques are more in agreement with the observation with the randomized trials. And in that case, it's important to know the risk of bias, that you can always have risk of bias. You should always address that part, and you should always consider all of these situations that we mentioned. Okay, so pretty much in these cases, we have zero risk of bias involved, but no other issues in this part. And this is the example that I mentioned, that if you have a similar risk of bias in other situations like inconsistency or indirectness or publication bias, you could consider a pooling of the effects. And this is a rare case. Obviously, I want to emphasize that we can say that it's pretty much cherry picking, but it's an real example. But the thing is that situations like this will be rare. So it was hard to find examples like this, that you have good observational studies with good randomized studies. Most of your guidelines, our guidelines will be, different in the sense of observational studies and randomized trials. And that's, yeah. So looking in the future, we will look forward to work with rare diseases, real world evidence situations. That these are together, interconnected HTAs. Looking for artificial intelligence for our guidance, so that will be very helpful. Remember the 19,000 scenarios that can be used with artificial intelligence. They can help us, and other situations like pooling RCTs in observation. What are the specifics mathematics in terms of that? How to address reading up the evidence of the evidence. There are some new guidance in grade, I know, that about dose response, but we can still consider other, like rush effects and opposing residual confounding. Update that grade guidance, specific differences in the domains, the grade designs, the observational designs. For example, these new techniques of IPTW, target trial emulation, etc. Those designs are inherently better in theory than any, let's say a case control study or a cross-sectional study or a cohort study without a proper assignment of the assessment of the confounding. And using DAX is also a thing that we should consider always in the sense of establishing causal effects. Okay, that's it for me. I was aiming to leave at least 10 minutes for discussion or question, if that's okay.
Yes, thank you very much, Carlos. Thank you very much for staying on time, for allowing room for questions. I wanted to commend you for your beautiful slides. I wish my slides were as nice as yours. The only question that I see on the chat is, would it be possible to get some kind of copy of your slides, maybe in PDF form? Carlos, that would be for you.
Yeah.
Be fantastic. Oh, do send maybe Madeline an email at the end of this and let us know that you want the slides. Yeah, any questions? I think Hassan has his hand up.
Yes. So Carlos, I saw in one example you said that you had, I think it was the one very close to the end, that you had observational studies that used a target trial emulation, and they clearly identified time zero, and they used propensity score matching or some causal method framework type of approach, and you still gave those a moderate, you still rated those down for risk of bias, right?
Yeah.
There was a footnote, I didn't see what the footnote says, but so you, I mean, so you have not been able to find a situation where you wouldn't do that?
Yeah, most of it is fear of, I'm going to accept it, it's fear of criticism, because you cannot say, or being more conservative. The example that I mentioned is this one, Gupta 2020.
Mm-hmm.
And this is, between all of these, this is with the only one that I would not write down for risk of bias, because of they adapted all the variables of the possible prognostic factors that can have an impact on the outcome. So the baseline differences between intervention and control group were well assessed, well adjusted. Time zero was well performed between this one. But even the authors of this type of target trial emulation techniques, they say there is still the possibility of residual confounding. So there is something, maybe some genetic factor that you don't know that may be imbalanced, or something that out there. But essentially, you don't have evidence of that, but you have absence of evidence of that. So yeah, it's impossible to say I'm 100% sure that we don't have residual confounding. But that's why the precaution is just to rate down one for risk of bias. But yeah, it's a judgment call, and I've seen people not writing down at all. But that will be, frowned upon, I think.
Yeah, I mean, I hope that we come to the day where we have a situation where if we have a couple, say a few studies that used rigorous methods, few non-randomized studies that used rigorous methods, and they were able to identify time zero and adjust for everything they know of, that we cannot rate them down. Perhaps we can exclude the other studies, right? So let's say I have 10 observational studies, 3 of them were well done. You can get rid of the 7, and then, especially in the situation where the results are identical to the RCTs, right? And then not rate down, because it looks like we're holding a double standard where we, RCTs can have all kinds of limitations, but we don't have that view of always rating down.
Yeah, and I agree totally. Actually, if you see this outlier here, this is one that with the highest risk of bias. They included because the authors of this one, they still use the IPTW. But you see that there were other issues with the risk of bias. So the most highly risk of bias is this one, and the others all use IPTW, and Gupta use also the target trial emulation technique with intensive assessment, blah, blah, blah. So yeah, there is a lot of things to discuss that, and in your protocol you can say if your scope review you see that you're gonna have several target trial emulation techniques, you can say I'm only including those ones, and that's it. And yeah, that's a possibility. I think the future will bring us that.
Great. Carlos, I have a question.
Sure.
I think Robin's Eye is clearly a superior tool to Newcastle, Ottawa, which is the most commonly used tool for non-randomized controlled trials that was used before. But it's a little bit cumbersome to use, and I think a lot of systematic review authors have still not made the jump to Robin's Eye. If you're thinking about doing this kind of integration, is it critically important that you use Robin's Eye to get a more nuanced assessment of how well these studies were done, or what's your guidance?
Yeah, I mean, my first thought was, you have a preference. Well, I have a preference to use Robin's Eye in this, especially if I consider in this integration. Great standing not saying everyone you should use Robbins. You can use Newcastle or the CASP one or any other tool that addresses that. But you should always try to consider or keep in mind that if you use those tools and you follow the great guidance, you will start as a low certainty evidence by default. And in that case, you go ahead with the other things. I mean, you can only rate up if you have a high dose response or large effects or any positive confounding. So yeah, that's the only thing. That's why with Robbins you have more possibility of be more specific, more granularity on saying this is the issue here, this is the issue there in the randomization. Because there was no randomization, we have this possible confounding because time zero was not there, or the IPTW was not used or was used, and so you have a possibility of that. Yeah.
Good. Carlos, there are 2 questions that have popped up in the chat. One of them relates to rare diseases and the use of registries. I think this question also pertains to so-called real-world evidence, and I think this is a question as to the value and the future role of this kind of evidence.
Yeah.
Maybe you can comment on that.
Yeah, that's a very interesting question, and there is Gray is working on some group in 1 or 2 groups, one in real-world evidence or in rare diseases, working on the use that we can have in both. I mean, cooperation, and see what can we do with those situations. For now, my advice would be to consider always starting as an example, this example, that rare diseases, sometimes you can address the same issue here as rare diseases. If you have a rare disease and you don't have a possibility of randomized trial, and you say, okay, this is the effect of the intervention based on this comparison with an historical control, which is a very common situation. In that case, you can still use the certainty of the evidence, and you say, okay, this certainty of the evidence is very low because of this comparator or was not adjusted or whatever. But you always have in mind your target trial, and you can see what are the problems here because of your target trial in your mind. You know that this includes a lot of risk of bias that you have to address, how to balance these two. What is the best technique to address these imbalances in baseline characteristics. So should I use the historical control? Can I use a make to compare these two ones, or an IPTW, or any other technique that you can find? Yes, it's possible, and you can still address the rest of the grade domains. So you can say that this risk of bias is because of this, and address the rest of the risk of bias domains that you have in your your table. If maybe there is, if you have more studies, is inconsistency, or the indirectness, or the imprecision of the effects, etc. So you can still use grade and address that. The issue that I've seen a lot with rare diseases and that issue is that we want to improve outcomes, and we want to obtain all the evidence that is possible. Sometimes we go into the point of wanting to increase the certainty of the evidence because it's a rare disease. So that's the only thing that we usually find. And I mean, I hope that will be possible, but evidence is evidence. Numbers is numbers. The numbers are cold. We cannot increase that. But I mean, but you can do that technique. I mean, we can improve things. The good news is that we can think about this, and we can tell the future researchers, this is the best that we can obtain. Use it, or balance the baseline characteristics, use target trial emulation, etc.
Good. I think we have time maybe for one more question. There's another question in the chat. I think it's about practical issues. If you know you're going to include, you think you're going to include non-randomized studies, right? Are there eligibility criteria for these studies that might help you in your job, like limiting yourself to prospective studies? Do you want to comment on that?
Yeah. I mentioned something quickly about using only the target trial emulation, for example. If you have in your scoping review, let's say you find that there will be 3 trial target emulations and 10 case control studies. Well, I can say that from the beginning, from the protocol, I will only use prospective cohort studies that use target trial or IPTW, like the COVID-19 example. So yeah, definitely you can make your in advance your selection of studies, or even after you can do subgroups and say what is the difference between the different designs and observational studies, and you can see differences in that case, and the decision maker can take more, a better decision based on that.
Good. Well, we are right on time. I think this has been a fantastic presentation. We're much indebted to you, Carlos, for doing this webinar. Madeline is posting information on our next grade workshop, and there will be future webinars too. So please stay tuned, and thank you very much for being here today.
Yes,
Thank you very much. Sorry, thank you.
Thank you, Carlos. Thank you all for joining, and we look forward to seeing you in the next one. Have a great week.